Ascites is common in the office as well as the inpatient service. Curvilinear, sector or handheld transducer should be used with an initial depth of 15 centimeters. A pouch of Douglas should be included in addition to Morrison's pouch. It's also useful to include views from the right iliac fossa, particularly when planning paracentesis and helping to avoid vascularity and inadvertent injury. In the thyroid, a high frequency or handheld transducer should be used with an initial depth of 3 centimeters and a small organ setting. The thyroid has liberal landmarks, including the common carotid artery, the internal venous jugular, the isthmus, the trachea, and the esophagus. Questions include: is the substance homogeneous? Is there lymphocytic infiltration? In the event of a nodule being noted, its echogenicity is important: hypoechoic, isoechoic, or hyperechoic. The structure: solid, mixed, or cystic. The margins: well-defined, irregular, infiltrative. And the presence of calcification: microcalcification, macrocalcification, or eggshell calcification. Finally, the vascularity should be noted. The eye constitutes 3% of all emergency room visits. Ultrasound is useful for retinal detachment, which is a true emergency, and ultrasound has a sensitivity of about 97%. It's also useful for diagnosing vitreous hemorrhage and detachment. A tegaderm film is placed over the eye and a generous amount of gel used. High-frequency linear probe. And note that in the butterfly, there is an ophthalmic setting. It's also important to see the origin of the retina. The optic nerve must be visualized in this case. Usually both longitudinal and transverse views are obtained. Deep venous thrombosis is common. Curvilinear or handheld transducer, perhaps a linear if the build is small. Deep vein setting with an adequate depth starting at 5 centimeters. Mild external rotation of the hip is helpful. The entry of the long saphenous vein, although it is part of the superficial system, into the common femoral vein should be noted. Thrombosis in the long saphenous vein may well extend into the common femoral. If the femoral veins are negative, restart at the popliteal vein and progress distally to the trifurcation. If the femoral veins are positive, progress proximally, if possible, in the iliac vessels as far as is practical, in case TPA might be indicated. On tennis leg, curvilinear or transheld transducer, perhaps linear if small build, should be used. A musculoskeletal setting should be chosen, and examination should then begin with the medial gastroc. The participant is usually middle-aged, originally moved forward quickly from the baseline of a tennis court, experiencing sudden pain and disability in the calf. They're often told that they have an Achilles tendon tear. They do not. They have a muscle tear involving the medial gastrocs, traditionally called tennis leg, and originally described in 1883. Difficult peripheral venous access is a frequent challenge. An ER study demonstrated that ultrasound-guided placement of peripheral IVs reduced the need for central venous access in 85% of patients. Arteries can be differentiated from veins based on pulsatility, compressibility or lack thereof, wall thickness, and Doppler appearance. Arterial walls are thicker, more echogenic, and less compressible. The transducer should be positioned proximal to the area of insertion, within the operator's direct line of sight. The arm should be fully extended and externally rotated, with the palm facing upward. Tourniquet should be placed proximal to the area of insertion. Most common insertion sites should be scanned in transverse plane using a linear or handheld transducer. The imaging depth should be set to 2 centimeters to avoid vessels deeper than 1.5 centimeters, which have a lower likelihood of success. The ideal vein is large, superficial, and distant from arteries. FAST-D was described in a study of lower extremity gunshot wounds in Argentina. The presence of a triphasic waveform in posterior tibial and or dorsalis pedis had a specificity of 100% and a sensitivity of 100% for excluding significant arterial injury in the thigh. The presence of a biphasic or monophasic flow required further workup urgently. This is problematic in the elderly, who frequently have biphasic flow in normal circumstances. Note that when you're collecting images, the acoustic or Doppler angle should be between 30 and 60 degrees. It's also possible that the FAST-D examination may have significance for the management or exclusion of suspected compartment syndrome.